In today's video, I spoke with Jes, a woman on a mission to transform menstrual health after her own 17-year battle with PMDD nearly claimed her life. Jes is the founder of Her Mood Mentor, a virtual premenstrual clinic. Jes combines her expertise as a menstrual health educator, board-certified coach, and nutritional therapist to help women heal instead of deal with hormonal mood symptoms. During our conversation, we defined PMDD. What is it? What are some treatment options for PMDD, pharmaceutical and natural? And how does PMDD overlap with endometriosis? Is it more common in endometriosis? And how can endometriosis patients effectively support their bodies with endo and PMDD? Thanks for tuning in. Now to our video. Awesome. So I'm joined today by Jes, who I've had the pleasure of connecting with over socials. I think we can say that we're like socials buddies, at least over the last few weeks anyway. But I'm really happy to have you, Jes, because I don't know anything about PMDD, and you are a PMDD expert. Do you identify as a PMDD expert?
I mean, there's always more to learn.
Of
I
course.
certainly don't know everything there is to know about PMDD, I'm sure, but I have a long lived experience and I'm moving into my 7th year in practice helping others. So I think I fall into the category.
Yeah, I'm an expert for sure. And I totally agree. You can't know everything about anything, but I'm sure you know quite a bit, which is why you're here and why I'm so happy to have you here to chat about this topic. I think a great question to just kind of get us rolling in this interview is, who you are. Maybe you can give us a brief introduction of who you are, what makes you a great person to talk to on this topic. And before I hit that record button, you started saying some really unique things about what makes you a great person to talk to about this. So yeah, I'd love to hear from you who you are and what makes you a great person to talk to on this topic.
Yes, so my name is Jes, as you already know. And my practice, I run a virtual premenstrual clinic called Her Mood Mentor. I did not get into this work by choice. It was kind of a, divine intervention or fate, whatever you want to call it. But I was living for 17 years undiagnosed and misdiagnosed with what we now know was PMDD. And those years were very brutal, very difficult for myself, my family, my friends, my partners during that time. So basically from the time I got my period around the age of 12, 13, I think I had just turned 13, up until I was 27. And I didn't get a PMDD diagnosis, I think, until I was 28, but it was when I was 27 that I found out what it was by hitting rock bottom with another PMDD episode, unfortunately. So there was a lot of confusion during that time because I was misdiagnosed as bipolar, which is the most common misdiagnosis for PMDD. Borderline personality disorder is also another common misdiagnosis, but not as common as bipolar. And I was treated and medicated as a teenager with antipsychotics for bipolar disorder, which I did not have. So it was a long road, and I think when people hear mood disorder, I don't know what they think. I suspect they have an idea of, okay, this person is moody, but they don't really understand the implications on not only your quality of life, but everyone that is close to you. So I was dealing with a lot of self-harming behaviors. Suicidal ideation is a common symptom of PMDD, and so that was going on. Disordered eating, very common. Fatigue to the point where I couldn't get out of bed for days, sometimes weeks on end. Obviously, the mood swings played a role, but there was also joint pain and bloating and so many symptoms that I was dealing with. So it was a long and unfortunate time to be living with a misdiagnosis because I wasn't really able to move forward. And in 2017, I was kind of at a low where I went to my physician again and I said, I have severe PMS. I don't know what to do. I really want to get this under control, which I had been saying for decades at that point. My mother started taking me to the gynecologist when I was 13 years old. I was put on birth control for these symptoms by the time I was 14, and just nothing helped. And so they put me back on a birth control, and it sometimes, unfortunately, the hormonal medications can make PMDD symptoms worse, and that's what happened. And so I almost lost my life during that period of time that I tried the birth control again. And at that point, it was like, this isn't living, so I'm going to have two choices here. I can take that route, which is very loud in my head, or I can figure out a different way forward. And I'm grateful every day that I gave myself another chance after 17 years of trying to figure this out, because I learned to reduce and manage my symptoms within 3 months, and I had a symptom-free period for the first time. And when that happened, it was amazing. Of course, my period came and I didn't want to die beforehand, but I also recognized how much I had been suffering. You don't really know how sick you are until you feel better. And it was a beautiful and heartbreaking moment, but it was in that moment where my life changed, and I realized this is what I'm here to do. I have to help other women sort this out. And then I went back to school and built this practice, and now that's what I do every day, all day.
I know.
That was a long story.
No, that was beautiful. And we're so happy that you are here and sharing your knowledge and your skills to help other people who I imagine are experiencing a lot of the same symptoms you were experiencing, which sound very scary and very life altering. Maybe we can I have so many follow-up questions for you, but maybe we can take a quick step back and just define PMDD. What does PMDD stand for, and what is it exactly?
Yeah, so PMDD stands for premenstrual dysphoric disorder. It's classed as a cyclical reproductive mood disorder. It was added to the DSM in 2013. Before that, it was called late luteal phase dysphoric disorder, but it wasn't in the DSM. It was treated as a medical condition, not a psychiatric condition. And there's a lot of ideas of what is causing it. And I think you can relate to the take on root causes, where there's, never really just one root cause. There's a lot of things that are driving symptoms. We know genetics are a part of that, but we also know that epigenetics plays a role. So just because you have a gene for something doesn't mean you're going to have it. Your environment, your health history, so many factors can play a role in if that gene is turned on or off. We see signs of allopregnanolone, which is a metabolite of progesterone, impacting the GABA receptor, and that's suspected to be a potential cause, but there's some conflicting research on that. We also know that estrogen impacts neurotransmitter function, which regulate our mood, cognition, sleep, eating, things like that. So that can be playing a role. Our other main ovarian sex hormone. And then we also see structural changes in the brain for those with PMDD. And so like changes with the amygdala and emotional regulation and behavior from that. And we also see trauma playing a huge role in the hypothalamic pituitary adrenal axis, that stress response system, making us have a heightened stress response, and a lot of research around PMDD being linked to childhood trauma and adverse childhood experiences. So, when people come to me for a root cause approach, I really want to educate them, because you can get into this hamster wheel mentality when you turn away from conventional medicine and move into functional or integrative medicine, where you're just searching for the root cause, and it's like this scavenger hunt to find the one thing. And that's really detrimental, because it's too myopic, and it really is taking you away from all of the options that you have to feel better, where there's not just one thing. And luckily that's good news, because that means you have a lot of options to feel better and not just one thing, if that one thing isn't accessible to you. So
Exactly.
I'm on a tangent.
No, that was so helpful. I've learned so much about PMDD. Like I admitted to you in the beginning before we got on the recording, I know very little about PMDD. The one thing I did know is about that allo metabolite.
Mm-hmm.
But yeah, it sounds like there's definitely, based off of those potential root causes, or what we suspect could be contributing to PMDD, it sounds like there's definitely a lot of overlap with Endo, which was going to be one of my questions, right? Around hormones, around neurotransmitters, around trauma, implicated potentially in the root of PMDD. There was something else you had mentioned. oh, it escaped me. Anyway, I'll come back to it. So in the beginning, you mentioned, suicidal ideations, very low mood, fatigue. Are there other severe PMS? Are there other specific symptoms of PMDD where somebody can kind of go through the list and say, oh, yeah, I've got that, got that, got that. This could
Yeah.
be PMDD, just to help people recognize whether this may be something that they're affected with?
Yes, yes, let's talk about that. So, within the diagnostic criteria for PMDD, you need to have at least five of these symptoms.
Okay.
Um, but there are a lot more symptoms than this, and we'll get into that. But the core symptoms are going to be mood and emotional regulation problems. So, like mood swings, signs of depression, um, increased sensitivity to rejection is a really big one. So, that's more of like an ADHD symptom we usually see, but there's a huge overlap between ADHD and PMDD and just neurodivergence in PMDD, which hopefully there will be more research out. But the research that is currently out is shocking, how high the overlap numbers are. So the core symptoms, so mood changes, mood swings, things like that, irritability, anger, rage, conflict within your relationships, being depressed, feeling hopeless, feeling worthless, feeling guilty. A lot of shame and guilt comes along with mood disorders. Heightened anxiety and tension. PMS used to be called premenstrual tension. So that's just kind of a fun fact. And then like feeling, also in that category would be like with anxiety is like feeling out of control is a common symptom. And then losing interest in your usual activities. So more like common depression. So you need to be diagnosed, you would need to present 3 of, okay, so how does it go? Yes. So in order to be diagnosed, you have to at least have one of those core symptoms. I don't love the diagnostic criteria. Okay, I'm just gonna be honest because we all feel those things. But one of those core symptoms, but other symptoms would be difficulty concentrating, fatigue is a huge symptom, appetite changes, so craving food, having aversions to food, not having an appetite, feeling really easily overwhelmed is a huge one, super common. And then there's the physical symptoms. So not everyone with PMDD experiences physical symptoms, but there are many physical symptoms that can come along with PMDD. Most commonly are going to be breast swelling and tenderness, bloating, joint and muscle pain, and then weight gain, commonly from the food. Like we see a lot of disordered eating with binging and things like that. So it's a lot of symptoms. There are more than that, but you have to have 5 of those symptoms that I listed, and then at least one from that kind of list of 5 core symptoms.
Interesting.
So,
Diagnostic criteria. Yeah. I imagine a lot of those physical symptoms are stemming from the involvement of estrogen, right? In the
yeah.
PMDD picture. Interesting. Is it common, because you had mentioned a couple things like as you were sharing some of these symptoms, I was thinking like, oh, that could be a symptom of like iron deficiency, right? Like for example, in the case of fatigue or maybe some
Mm-hmm.
cravings or insulin resistance, right?
Mm-hmm.
Or elevated
Thyroid
androgen.
conditions. Yeah.
Right. So is it common then in Western medicine or in functional medicine or whatever kind of paradigm we're talking about to test some of these things to rule these out prior to the PMDD diagnosis?
So this should be done, but here's the thing, and this is so interesting, I feel, is
Mhm.
that before PMDD was added to the DSM, it was treated more as a medical condition. So more of that screening was in place. When it was added to the DSM, it moved from a medical condition to a, psychiatric mental health condition. And so it's creating this gap where women are falling through the cracks, right? You're being referred to your counselor, you're being referred to your gynecologist, where your gynecologist is a trained surgeon. They're not an endocrinologist, they're not trained as much as you would think on the menstrual cycle.
Mhm.
And it doesn't really matter either way because within conventional medicine, there's a script that is laid out of if you have this diagnosis, you're going to provide this treatment. That's just how it works.
Right.
So either way, the treatments are the same. But unfortunately, because this has moved more into the mental health realm, to get a diagnosis, you do not have to have that testing. You should have that testing. And I'm always advocating for my clients to have that, because the more I've done this work, the more I see those physiological drivers showing up behind these symptoms, and no one is talking to them about that. No one is assessing for that. It's just like, oh, this is a mental health condition, take an SSRI, which is just such a disservice, because we don't just have mental health problems. Like, the body is connected to the brain. And so why aren't we digging deeper and looking more closely into where this is coming from? And there are always things that we're finding at the clinic, like vitamin D status, histamine, thyroid issues, on and nutrient deficiencies. It just is endless. Never has anyone come to work with me and I'm like, there's no reason why. I can see no reason why you're having these symptoms. I mean, blood sugar regulation is massive, huge driver behind symptoms. So it's very unfortunate. And at no point in my 17 years of trying to get an accurate diagnosis, going in saying I have severe PMS, did anyone say it's PMDD. And then if they do run blood labs, they run very basic blood labs, only TSH, not looking at a full thyroid panel. Yep. And I have a history of family thyroid conditions. So it's very frustrating that there's not more education on the provider's part of how to screen for this and what other things could be used, and that we're just constantly handed, these are the options: birth control, SSRI. If those don't work for you, too bad.
Yeah, fascinating. So it sounds like not only are some of these, potential underlying contributors, not only are they common and likely with PMDD, but also addressing them can also start to give you a bit of symptom relief, right?
Very quickly.
Yeah. So I'd love to chat about both sort of the pharmaceutical and then the lifestyle diet options. Yeah, because one thing, again, I don't know a lot about PMDD, but one thing I've heard and read is that, like you just mentioned, right? SSRIs, birth control, these are common management options, right? Or I don't even know if management or treatment is the right word to use here, but and just I wanted to ask you too, how common is PMDD? Do we have any stats on that?
Yes. So the estimation is 3 to 8%.
Okay.
But with misdiagnosis being so common, I suspect it's higher. And again, this is one of the detriments to the DSM diagnostic criteria. We can all have those symptoms. None of those symptoms are unusual when you're
Right.
talking to a woman with, a female with a menstrual cycle. Like, a lot of these symptoms we're all experiencing. And PMDD is just checking the box of, yes, I have those symptoms. Yes, they fall during my luteal phase. Okay, 70 to 90% of menstruating females have premenstrual symptoms. So this is
Yeah.
the severe version of that. Like, if only 3 to 8, we're saying 3 to 8%, I feel that that's probably grossly underestimated. And again, the diagnosis, it's like, okay, this can be very transformative to be able to have a name to something that you're experiencing, but it's not telling you anything about why. It's just confirming, yes, I have those symptoms. And it can be kind of a dead end.
Yeah, I agree with you. I'm seeing more and more overlap between PMDD and endo. I suspect it's significantly more than, the new statistic 1 in 9 for endometriosis. I expect it's quite a bit higher than that. And I would agree with you. I think PMDD probably affects way more than 8% of women without question. So yeah, I'd love to chat about the management options.
Yes.
What are the pharmaceutical options, the natural options, and then I'd love even just to get your personal opinion on the pharmaceutical options. Are they effective? Do they work?
Well, I'm on cycle day 24 Sunday, so I'm feeling a little spicy. I'll try to keep it toned down.
I love it.
Um,
Talk to you about this.
I'm biased, I'm not gonna lie. Okay, so let's get into it. So when it comes to PMS, PMDD, along with many symptoms we experience as women, the conventional treatment is going to be SSRIs, antidepressants, SNRIs, some form of antidepressant, or birth control. Just like with, different reasons these things are being prescribed, but most common prescription that you're going to get as a female going to the doctor with any sort of symptom or ailment. And they can be life-saving. A lot of people do see positive results with the medications, but unfortunately, again, they're not screening for any generally they're not screening for any underlying drivers. If they are, they're using conventional lab ranges, and they're probably not running thorough blood labs and looking at it through like more of a functional range, right? They're diagnosing disease, treating disease. They're not looking at optimal health. So there's that factor. And then there's generally nothing else that's offered, and there's no education that's provided around, hey, this might help. It might also make things a lot worse for you. So you need to learn how to track your symptoms now and then be able to pay attention as you're bringing on this medication that's going to potentially alter you in lots of ways, right, to be able to pay attention how this is affecting you. Because something that I so commonly see with PMDD, and I think happens with other mood disorders as well, or personality disorders or anything, is there's a lack of self-awareness. And when you're in it, right? And when you start a medication, you're in it, and you can't really see clearly how it's impacting you. So it can be a slippery slope for those where it's making the symptoms worse, like it did for me, and they tell you, you need to be on this for 3 months for it really to take effect. Well, my life was almost over by 3 months. Like, I had lost my relationship, lost my job, lost my housing, like burnt my life to the ground for the, multiple times I had done this now. But no one ever told me, hey, this could make things worse. They told me stay on it. So I have some medical trauma, I would say, from my experience over that 17-year period. But I think it can, now that I've been working in integrative medicine for so long, I also have shifted my perspective where I see, okay, it's also not great to be so against conventional treatment that you're not willing to try something if you need it, because it can be for some people, it can be a good leg up where it's like, okay, we just need to get your head above water so you're not drowning, and then we can address some of these other things to help you feel better if the medication works. But it's not the solution. The medication isn't addressing any of the reasons why you're having these symptoms. It's a Band-Aid, if it works, for the symptoms. And what many of my clients see is that the medications will work for a while and then they won't.
Yeah, very comparable, I feel like, to Endo. And I totally agree with you. I am not anti any kind of medication for endometriosis. I just want people to be informed and, be supporting your body while you're taking this medication, maybe work on some of those, root cause issues. That's tricky with Endo, but still there are things similarly, it sounds like, to PMDD that you can work on to improve your quality of life, your symptoms, your estrogen elimination, inflammation, all that. So totally agree with you. I think meds can be very, very helpful. But I imagine similarly to Endo, they really need to be tailored to the individual. And on that note, I was curious, and you might not have an answer to this question, but is there any signs, anything in the blood labs, anything in the family history or genetics that might give you an idea of whether or not an SSRI or some other pharmaceutical may be a good option for you if you have PMDD? Or is it sort of like you need to try it and see if it helps? Is it sort of that type of a scenario?
So first I'll say there's no blood, urine, saliva, genetic, or imaging test to say like this is PMDD. Okay. Again, it's a mental health condition, so you're just ticking the boxes of these symptoms. I think like any other condition that you would go on to an SSRI for, you can do some genetic testing to see how you might react to the SSRI, but that's not really going to show you in context of PMDD. It's just going to show, could this be a good option for you genetically or not. And I'm not sure how that testing works. I don't prescribe, so I don't run those tests, but I do know it's not specific to PMDD treatment, the results that they get.
If you were like, let's say you go to the doctor, you're having these symptoms and they present you with a pharmaceutical option, is there anything in the symptom picture in the history that might indicate whether that could be a good option for you, or whether, like in your case, Jess, it's not going to be a good option for you? I imagine there probably isn't, but I was just curious if there is anything that might kind of give you some indication of that.
No, no.
Okay,
Other than,
fair.
like I said, other than the genetic testing that it says how you might react to an SSRI, there's nothing that I'm aware of out there that's going to be able to tell you, will this help with the PMDD? It's really trial and error.
Right.
And with any medication, there's going to be side effects. And so it can be hard to know what's happening, like I said, unless you really get education. And unfortunately, your physician, it's not really their job to teach you all of the things that you need to know when you're navigating this. And it's such a bummer because there could be somebody there that's giving you informed consent instead of just handing you a pill and sending you away. But you really need to monitor the side effects and your symptom progression while you're on the medications. And you need to know if it's something like an SSRI, those weren't designed for long-term use. So you need to use that time to bring other support in to get better while you have the SSRI on board if it's helpful. Because unfortunately, many of my clients now, they were slapped on an SSRI when they were very young or, decade ago, and now they're trying to come off. And unfortunately, the withdrawal symptoms from SSRIs are quite common, and many of them overlap with PMDD symptoms. And so they'll feel like, oh, I'm going into a regression with my PMDD, and it's actually withdrawal symptoms. So you can really get yourself into stickier situations by using these medications to try to feel better if you're not informed on how to use them in a way that is safe. And like you were saying with the birth control depletes many essential nutrients within our body that we need to address PMDD. And so again, if you don't have someone who knows what's going on here, you're really just like out there, and it's like the Wild West. I mean, women are just on Reddit clinging to somebody else, what helped somebody else, without any understanding that your body, your lifestyle, your genetics, everything about your life is different than that person. And then feeling really hopeless when things don't work for you because you don't have the education and the understanding of like how to look at this as a bigger picture. And these women really need support and education. And that's why I'm like so fired up about doing what I'm doing, because we don't need more hopelessness with this condition. It's like, we've got plenty of that. Okay. Let's like bring something in to be the antidote to that. And it really is education and awareness.
I hear you. I love it. Totally agree. What about some natural intervention? So this is, I think, your area of expertise, right? The natural stuff.
Yeah.
What are some?
That's my jam.
Yeah, your jam.
Well, and it's funny, Cindy, because people will come into my account and into my DMs and comments and be like, you're not a gynecologist, you're not a doctor. And it's like, I deliberately chose to take the educational and professional route that I did because of what helped me and what changed my life. Not because I'm not capable of becoming a gynecologist or a doctor. It's just those practitioners didn't help me. So I followed the route to do the thing that I saw the best results with. And those are lifestyle and diet. And so, it sounds so basic, Cindy, but I know you're going to get this. I start with the foundations.
Yeah.
It is key to start with the foundations. If you are not able to digest your food properly, if you are dealing with dysbiosis of any kind, infections, I mean, if your blood sugar is dysregulated, which everyone's is, if you're dehydrated, if your minerals are imbalanced, just on and on, you're not going to feel good throughout all of the phases of your menstrual cycle. And so why are we going to jump to this really elaborate, targeted protocol for this one thing that we see going on for you if you don't already have these foundations in place? we're wasting our time. And so that can sound, that's not sexy, you know? It's not like, oh, but it's the reality. And I get it because I've been there. I've lived with this for so long. And it feels like, okay, I am genuinely like suicidal or homicidal in some ways. Like the anger and irritability and rage is so hardcore. How could hydration and minerals make a difference? It sounds stupid, okay? I know it sounds stupid, but that's a lack of understanding of the female body and of human physiology in the first place. Thank goodness. Because if we needed these elaborate, expensive protocols to help everyone feel better, there's really no hope for us. And women are just continually amazed as they go through my program and my courses where they're like, I thought I was going to have to change my entire life and overhaul my entire diet and become this different person because the symptoms were so severe. But I did these few things and I built on it, and I also brought in management techniques. So that's something else we were talking about before we started recording, where I don't really see this in the PMDD space because many of the practitioners don't have PMDD or haven't experienced PMDD. And so they don't really know what we need. We need reduction techniques because we want to feel better. So let's start there. We got to get you feeling better first as quickly as possible. But we also need management techniques, because how you manage the symptoms is going to really make or break. Are you in a relationship? Do you have a job? Do you have custody of your children? Are you in jail? I mean, are you alive? It's serious. So we can't just focus on reducing the symptoms. Again, a lot of the symptoms are mental health symptoms. So we need to work on mindset. We need to work on automatic negative thoughts. We need to work on management techniques that can help you manage the symptoms in the moment when you're symptomatic. And then when you're not symptomatic, we're going hard with reduction techniques so that when the luteal phase comes around, you're not as symptomatic. And if you're not as symptomatic, it's easier to manage. So it's this, this revolving process.
Yeah. And back to what you were saying about the foundations and, not being so sexy. It made me laugh actually, because you're like, we all have blood sugar dysregulation. Isn't that the truth? I mean, stress is going to contribute to blood sugar dysregulation, poor sleep, FOMO, staying up, scrolling on the phone till 1 o'clock in the morning. That's going to contribute to blood sugar dysregulation. Going 8 hours between meals is going to contribute to blood sugar dysregulation. It's just, yeah, it made me laugh because it's so true. I think we're all at least a little guilty of that. But the other thing I was going to add is that, yeah, the foundations. And if it's just one thing, like maybe you're working a job where you're not always able to get to bed at 10 or whatever it might be. Okay, that's probably going to contribute to the symptoms of PMDD a bit. It's definitely going to contribute to the symptoms of endo a bit. But once you start like stacking, if it's like the sleep dysregulation, right, or not getting good quality sleep, and then on top of that, you're skipping meals, the meals aren't well structured, you've got stressors coming from, everywhere, personal, work, and those things start to compound, and then it becomes, I think, such a significant problem, right? It's, your entire foundation is rocky when all of those things are in disarray. So, yeah. Very, very true, right? Those foundations and how important they are. You look like you
It's an escalation and a cascade. I mean, not only hormonally, but just in your life. And I think what else people don't understand, and so much of this comes back to proper reproductive health education, which we did not get. I was 27 when I learned there were 4 phases of the menstrual cycle. Yet for 17 years, I was trying to address something related to my menstrual cycle, and I didn't know what it was. It was like my bike was broken and I was going over there. I don't know what the parts are. I don't know how they connect to each other. I don't know what the tools that I need are. I don't know how long this is going to take, but I'm doing it. Yeah. And I did that for 17 years. And now looking back, I'm like, well, no wonder. And the thing with PMDD is that, unfortunately, this, it's a mood disorder that only affects females. Females are notoriously hard on themselves as it is. And what happens is these women just implode on themselves. They hate themselves. They're the one that has all this guilt. They're the one that has all this shame. And that's a internal stressor, along with the blood sugar dysregulation, all of the foundations being out of place. And what people are not getting, that I'm trying to come to, is like, supporting your menstrual cycle is an every single day thing, just like supporting your health is an every single day thing. So if your luteal phase, where the PMDD symptoms are happening, they're only going to be happening during the luteal phase, maybe a couple days, few days into menstruation, then they are alleviated. Premenstrual dysphoric disorder, 4 phases of the menstrual cycle: menstrual, follicular, the ovulatory phase, and the luteal phase. So you can be experiencing these symptoms for 16 days if your luteal phase is 16 days long. 10 to 14 days is common. And they're not connecting the symptoms to their menstrual cycle because the symptoms onset so commonly at around ovulation. If they have an episode and then they bleed enough times, they're probably going to recognize, oh, it's my period.
Right.
But the symptoms are happening so much earlier that they're not connecting it to the menstrual cycle. And then they're only waiting until the luteal phase to address the symptoms, when that's when we're managing symptoms, not reducing symptoms. Mm-hmm. You following me? Like, you can't reduce symptoms when you're in an escalation phase. Right. Like, if I'm having a panic attack, I'm not going to be like, I'll regulate my blood sugar and drink some water, like, no. Right? I have to manage. Yeah. Yeah. Right. I'm in survival mode at that point. So there's a lot of victimization that comes with this experience because it's cyclical, and there's a confusion around why it's happening, that it's even happening. There's a lot of denial, repression, and the saddest part is that the women I work with just turn on themselves. The mentality with the automatic negative thoughts that come with this is, I'm worthless. I don't deserve to be here. I'm not good enough to be here. So I should just not be here anymore. Eventually you end up at that place. And that, again, is a lack of understanding of the female body, because if you're not supporting yourself every day throughout every phase of your menstrual cycle, regardless of PMDD, you're going to have premenstrual symptoms, because the quality of your ovulation determines the quality of that corpus luteum. And if that corpus luteum, which is a gland that produces progesterone that was created from the sac of the egg that you ovulated, which is a massive vascular event for your body to go through. Right. And many of these women are moving into the luteal phase deficient in progesterone, which you brought up, is a treatment, not a common treatment, but used to be the primary treatment for premenstrual tension. But there's so much controversy around PMDD and the treatment. Oh my gosh, we could do a whole nother talk on that. It's so interesting. Yeah. But the quality of your ovulation is going to determine the quality of your luteal phase. So if you're having really bad luteal phase, girl, we got to go all the way back to day 1 of your period. And not only day 1 of your period, but the whole time that follicle was being developed, which is 90 days. So if you're having a really bad menstrual cycle this cycle, you can't just say, oh, well, what happened over the last 2-3 weeks? You have to go back months. Exactly. Yeah, there are so many things you just said that I would love to comment on and ask like follow-up questions to. Just like a little like interesting nugget of information. I've been seeing more and more patients, more and more women with endometriosis. And we know that endo is an estrogen dependent condition. So this is what's a little bit strange about it. But I've been seeing more and more women who actually have very low levels of estrogen, And what's interesting is that they all have something specific in common, and that's that they're very hard on themselves. They don't like conflict. There's a lot of that like internal, what's the word I'm looking for? Like blame, guilt, like a lot of that. And so I just wanted to bring that up because you made that point about that connection with PMDD and the blaming and the negative emotions about self and things like that. So mind-body connection, huge. And it sounds like there's also a massive mind-body connection with PMDD as well. I don't know how much time you have, Jes, but I was curious, and if this is like a huge topic and it's not something that we can talk about in a few minutes, we can totally maybe leave it for another time. But
You mentioned in the beginning that there are a couple of things that we know, or that we think at least, could be part of the root cause of PMDD. Like you mentioned neurotransmitters, you mentioned estrogen, blood sugars. I wonder if maybe you can offer, and with the caveat that you have to be treated individually, right? It's a everybody's genetics and diet and lifestyle and foundations play into how PMDD affects you. But I wonder if you'd be willing to offer maybe like one small little nugget, like one little intervention that people can focus on in each of these areas. So for example, if like, let's say estrogen is involved in your PMDD picture, what's like one intervention there, maybe for the neurotransmitter piece, maybe just one each for those two?
Yeah, we can do that. Um, so for estrogen, so a lot of these symptoms, PMS symptoms, are driven by an excess of estrogen and not enough progesterone. So we want to make sure we're metabolizing estrogen throughout the menstrual cycle. Now, I wouldn't say this is like the number one tip that I would give people, um, is around estrogen metabolism, but it is an important one. And I think something that I talk about here a lot, because I'm always trying to take a food first approach, is making sure that you're eating enough fiber in your diet that's going to help metabolize that estrogen through. So I love like a raw carrot salad, eating more raw carrots, adding more fiber into your diet is going to help metabolize that estrogen. Pooping every day. I guess if there's any tip, that's like the tip, and how you get there. It might be more fiber, it might be more hydration, right? Lots of foundations are going to play into that, digestion, bile production, but poop every day.
Yeah, I agree. I would agree. I would apply the exact same tip to people with endo. So yes, love it. And what about neurotransmitters?
So yeah, so neurotransmitters, I don't think people realize the impact that sex hormones have on neurotransmitters and hormones in general, but um, a lot of times when we think of hormones, we only think of estrogen, progesterone, we think of cortisol. We don't realize insulin is also a hormone, right? There's a lot of other hormones in the body. Neurotransmitters are hormones also. So, but neurotransmitters are made from amino acids. And if there's something I see a lot of things. But one of the most common things I see in the population that I work with is that they're not eating enough protein.
Same.
So
Same.
protein equals amino acids in the body, amino acids equal neurotransmitters, and you need to eat a lot of protein actually. It's interesting because I was talking to a dietitian recently and I was telling her, I'm recommending 90 to 100 grams of protein for women with PMDD, and she was so offended by that number. And I was like, wow, you're really not up on the latest research in women's health and protein consumption, because that's actually like sometimes more on the conservative side from what I have seen people recommending. So if you really look at it, like one egg generally has around 6 grams of protein, and a lot of the women will be eating, no protein for breakfast, or like 2 eggs. So you're getting 12 grams of protein when we're trying to hit 30, 35 grams minimum per meal if you're eating 3 meals a day. And that's, again, still a conservative recommendation. It can be hard to get enough protein, but you're not going to have proper neurotransmitter production in the body if you don't have amino acids coming into your diet, and we're getting those through food. Most bioavailable is going to be animal-based sources. Unfortunately, I'm sorry for all my plant-based babes out there. I work with a lot of them, but that's the reality of the situation. It doesn't mean you have to switch over, but you need to be aware of, okay, you're going to be eating a lot more carbohydrates if you're plant-based, and you're going to have a harder time getting those amino acids. So you even have to be more diligent, do more meal prep, have more education. And unfortunately, so many of the women I work with are neurodivergent. And so neurodivergence and PMDD and a plant-based diet are a nightmare when you're a nutritional therapist, if I'm honest, unfortunately.
I hear you. And I mean, like, we could take it one step further and say, in terms of the importance of protein, how it's then needed to make hormones and enzymes and all the implications of that for your ability to absorb nutrition, for good gut health. Speaking of gut health, a lot of neurotransmitters made in the gut. So I imagine there's probably, quite a profound overlap there.
Yes. Yeah. I mean, when people talk to me about like root causes, yes, I can get into those specifics that we talked about earlier, but really it's inflammation in the body, and it's going to come back to the gut function.
Yeah.
And again, that like drives us back to the foundations, which are more elaborate than the gut and inflammation, but we have to start there really with any illness that we're experiencing, whether it be mental or physical.
Okay. Yeah, agreed. I don't want to keep you for too much longer. I did want to ask you, I wanted to make sure to ask this because I've read so much about it. Vitex. Vitex as a natural supplement. Do you find it beneficial? I know that there is some books
There's
out
quite
there.
a lot of
Yeah.
research on Vitex. Even highest quality research studies, on Vitex, which is interesting because I'm like, who's funding these? Because you're not going to make a bunch of money from Vitex.
Right.
Vitex is an herb, so it's also known as chaste berry. It's a Mediterranean herb, and it can block the release of not prostaglandins, but it could do that now. Prolactin. Block the release of prolactin, which can lead to a lot of that breast swelling and tenderness and some of those estrogenic symptoms. And it can increase dopamine, but it can also play a role in balancing out estrogen and progesterone, is what they think. And so it's commonly used, and there are some studies that say it's as effective as fluoxetine, which is an SSRI that's commonly prescribed. There are other studies that say it's not. That makes me ask, like, who's funding that study?
Right.
But it is a great option. It's herbal. It's going to come with a lot less side effects than taking medication. So I think it's a good place to start. Or not a good place to start. It's a good thing to consider, but I wouldn't start there. Because again, if you're not addressing the foundations, you're going to continually have problems with estrogen and progesterone regulation. You're not addressing that by taking Vitex. It's, again, kind of another Band-Aid approach, but it can be something that's on the table that has been shown to be very helpful. You don't want to take this if you're on birth control, because it's going to impact your estrogen and progestin levels, potentially, synthetic progesterone. If you're pregnant, you don't want to take it if you're breastfeeding. You don't want to take it if you're on hormone replacement therapy. You don't want to take it if you are taking ADHD medication, because it plays a role in that dopamine system. Or if you're on antipsychotics or some other psychiatric medications, same, because it plays a role in the dopamine system. So there are some real caveats you want to be aware of there, but it's definitely, I'm a huge fan of herbs. I know a lot of people are scared of herbs, but I love Vitex and chaste berry, and I definitely think it can be something that is on the table. Never have seen a conventional practitioner recommending that.
Yeah. Oh, yeah. I don't doubt that. And just to go back to your comment about the foundations, of course, I agree with that. And like you mentioned, Vitex, works by lowering prolactin, which we wouldn't want to see high in somebody who's not pregnant or breastfeeding. But prolactin very often will elevate in response to blood sugar dysregulation. So that just kind of takes us back to the foundations, right? And one thing that prolactin actually, that what prolactin will do, which is what Vitex will help kind of normalize, is it can suppress LH, kind of prevent or weaken the quality of that ovulation, and therefore you're not getting that really good progesterone produced on the other side of ovulation, which obviously matters very much for PMDD as well.
Yes. Yeah, isn't it interesting how they're finding it can impact FSH and LH? You're like, okay, an herb impacting the pituitary function is, I mean, obviously it can do that, but it's so interesting to see it on the page, like powerful little plants,
Sure. Yeah. I mean, before we had meds, we had plants. Okay, so Jess, I think you mentioned already a little bit about this, but my last question to you is, just around the overlap with endo and PMDD. You in the beginning of our call, you did mention quite a bit actually in terms of the overlap around estrogen, around some management options. I don't know if there's like a simple way to answer this question, because I know I've kept you a really long time already. I don't know, do you have anything to add from that?
So I will say that we don't see that like people with endo are more common to have PMDD, or people with PMDD are more likely to have endo. Like there's not a relationship like that we are aware of. And I would
Okay.
say that plays out with the population of women that I'm working with. Some of them have endo, but it's definitely not
100%.
half.
Yeah.
Yeah,
Fair.
even. A lot of women with PMDD mostly have psychological symptoms, but when they are presenting with strong physical symptoms, especially cramping, ovulation cramping, some constipation, some other digestive symptoms that are pointing me more to endo, then I start asking those questions. But like we talked about when you came into my community, it's harder to get a diagnosis for endo than it is for PMDD, like big time. You can just get a diagnosis for PMDD so easily. It's a lot harder for endo. So there's some mystery around, okay, what's going on here? But some of the symptoms overlap as well. So like the fatigue, bloating, anxiety, depression. I'm sure you see a lot of that in your endo population, digestive issues. I'm seeing that also. So inflammation in the body and digestive issues are going to result in a lot of the same physical and menstrual and mental health symptoms. So I would say that's where the overlap is more. And then addressing it with foundations is definitely more of an overlap than PMDD causes endo or endo causes PMDD, or there's some sort of other link there.
Yeah. So foundations are key for both PMDD and endo. Did you have any final little nuggets, tips, anything that you want to leave
Well,
our...
I really just want people to know that this is not a hopeless condition.
Yeah.
You don't have to continue suffering, and it's also not normal to be experiencing any severe menstrual symptoms, or premenstrual symptoms, whether they be mental or physical. We weren't brought onto this planet to suffer because we have a menstrual cycle. So don't believe that you just need to suck it up and white knuckle it through this. If you need help, find help, and know that you have more options than antidepressants and birth control. There's so much more out there, and really working with someone who can help you peel back the onion layers and see what are some of these drivers and help teach you some skills and some education around your cycle and around these symptoms that can empower you, because you can live a completely different life. Things that feel impossible to you. I couldn't hold a job. I couldn't maintain a relationship. I couldn't move forward in my life for so long. Now I'm married. I own a home with many acres and a garden. Like, these dreams that I just believed were going to be impossible for me because of how these symptoms impacted me each month. I truly believed that I would be dead by the time I'm 35. And here I am, living a completely different life. And that can happen for you too. There's nothing special about me. It's really learning to support your body and learning to see the symptoms as messages, right? The symptoms aren't punishing you. You're not a victim to the symptoms. The symptoms are the communication that your body has to talk to you. There's no DM capability here, right? You're going to get a symptom. And so you have to learn how to interpret those symptoms and work with those symptoms and change your perception of the symptoms. And you can change your life.
And that's a beautiful and profound message to end off our chat. I will link to your socials, your website, your programs, all that in the show notes. So Jes, you're certainly very passionate. I love chatting with you on this. It was really amazing to hear everything you had to share. So I will link to all that for anybody watching who would like to connect with you. And just a big, big, big thank you for your time today. I really appreciate you coming on and sharing your expertise. So thank you so much.
Thanks for having me, Cindy.
Thank you so much for tuning into today's video. I hope you enjoyed it. If you haven't already, please like this video, share it with a friend, and hit that subscribe button for all the endo and fertility content. And I will see you in the next video.